Hey, deserving listeners, about a year ago, I did a deep dive on suicide at the request of many patrons. And ever since then, I've always thought that I didn't really like that episode because I was a little disorganized and a little long-winded. So I've been mildly obsessing about it, and over the past couple months, I have been revisiting my notes, condensing them to about a quarter of the length they were before, reorganizing things to make it easier to understand, shifting things around. So I want a second chance doing a deep dive on suicide. This time, more organized, I think better statistics, blah, 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 getting to the point faster, that kind of thing. In this episode, I'm going to be briefly going over some statistics, not too much. I'm going to talk about the history of suicide and culture. But mainly what I'm going to focus on is my model of why people think about suicide, and also my system of assessing and determining risk level and my treatment of suicide. That's the main thing. You know, the main reason why I'm doing this is because pretty much, I don't know, on a monthly basis or more often, I find myself with my supervisees, students, and trainees going over this material in a very detailed way, because suicide assessment for clinicians is a very complicated thing. By the way, this whole episode could also be applied to homicidal intent assessments as well. Suicidal ideation, homicidal ideation, the approach and the assessment and the treatment are basically the same. So consider it sort of a double dip in that way. But I find myself going over this with my students all the time, and there's just so many details. And so part of the reason why I wanted to do this actually was so I wanted to go over my notes and compile a document for myself that I could reference when I'm actually teaching this system to students and supervisees and trainees. So let's get into it. This is the Psychology in Seattle podcast. I'm your host, Dr. Kirk Honda. I'm a therapist and a professor. And this episode is just for patrons of the podcast. So if you want to hear this full episode, it'll probably be, 2 or 3 hours instead of 10 hours. And if you're not a patron of the podcast yet, you got to go to patreon.com. Go to patreon.com and become a patron of this podcast. And when you become a patron, you'll get access to this full episode, along with hundreds of other episodes that are only available to patrons. We have over 1,000 episodes, and 200 or 300 of our best are only for patrons of the podcast. So become a patron by going to patreon.com, and then you'll get access to this episode, which, especially if you're a clinician, I would imagine that this would be helpful to you. Even if you feel like you had some training in it, I find that this system that I've developed makes it so much easier for me to follow. One of the biggest benefits to me doing deep dives like this is now I have a system when I'm actually treating my own clients. I have my own notes, my own understanding of assessment and risk level and all that kind of stuff, and safety planning. Safety planning is actually pretty complicated. And so, become a patron. Do it now.